Okay, thanks everyone. I appreciate everyone being in attendance today. As new folks flow in, they'll certainly ask their questions along the way, but we'd like to make sure that this is our lightning webinar, which implies and is, it will be short and sweet and packed with information. So the goal is that within the next 15, maybe up to 20 minutes, we try to keep it 15 minutes. We try to give you as much information as we possibly can. We did have several questions posted to us prior to the webinar, so we'll start with those, and then we'll go to the Q&A that is in the Q&A box now. I'm Michelle Hager. I'm the managing partner of Blue Cirrus Consulting, and I'm with me here today is Amanda Buonocore, who's a consultant with Blue Cirrus, as well as working on her day-to-day job at Northwell Health, and Debbie Voyles, who is also a consultant with Blue Cirrus Consulting, but also works at Essentia Health, as well as the director of telehealth there. So with no further ado, I will start and launch into these questions. I think we've got 4 questions that are around coding. So I'll start with those, Amanda, and then we'll kind of pepper in some of the other operational questions that we had. I think we had 4 and kind of 3 around different types of questions. So we'll pepper in some of those operational questions. And then Debbie, I'll ask you if you want to add anything to any of the points that Amanda makes along the way, or you can just feel free to jump in. We are recording this session. This will be available on the Blue Cirrus website post this session. So thanks again for being here. So Amanda, what are some coding tips that you would recommend to store in your tool belt?
So I recommend that everyone keep track of the proposed and final rules from CMS. So those come out in July and November. Those are going to give you what might be applicable for the following year, as well as give you the ability to retort or send comments. In addition to that, you should look out for anything on the AMA agenda that's regarding these services and what might be applicable in the future and what changes are coming.
So is this the AMA panel that you sometimes talk about that you watch?
Yeah, so agenda items are typically published nearly 2 years in advance. So some people may or may not know, but it's pretty actively on the AMA agenda to delete the 99441 through 99443 codes, which were only applicable during the public health emergency, even though they've been CPT codes for quite a long time. The reasons behind that are intended to fix the guidelines associated with the codes due to the fact that they changed the majority of the guidelines that are traditionally associated with that code for the allowances during the PHE. So some people might be thinking, oh, I have telephone coverage into 2024. Will I have it post? Well, those codes are actually going to be deleted. So you should be looking at what their replacement codes are and what's encompassed in those replacement codes.
Yeah, really good point there. I'm going to jump to one of the other coding questions because I think it kind of dovetails into this. It's around place of service 10. So it looks like that's going to be in effect post. The question is, it looks like it's going to be in effect post the end of the calendar year through 2024, barring any updates prior to it. Are you in agreement with that?
Yeah, so POS 10 was created during the public health emergency. So, standard state happened with CMS in regards to reviewing telehealth because they didn't know in what year that the PHE would end. So annually, they still recognized and reviewed their own internal policies for what would happen if the PHE was to end. In that time period, there was allowances for certain opioid services to be conducted to a patient at home. Now, we know home is still not on the federal list as an approved location, but in order to encompass these services that they would allow via telehealth to be performed at home, they had to restrict or somehow separate them out from the use of O2. So they had created POS 10. POS 10 was created, I believe, in 2020 and placed on hold to the end of the PHE. However, I believe it's HIPAA that runs the POS. So once a POS is created, anyone could utilize it, right? to their own internal policies. So you might now see commercial payers saying we want 10 or 2. There is no specific guidance out there on when to utilize 10 or 2, with the exception of CMS saying 10 should be used specifically for those opioid treatment programs that allow that use of home. So with that in mind, you might have to consider figuring out internally how you are going to differentiate between a 10 or a 2 and identify the risks associated with using one or the other. Right now, there's not really a payment impact risk because both result in a facility payment, which means that you're only getting the professional charges, not the technical charges associated with the code. So misappropriation of the POS shouldn't result in an overpayment, but you might have to follow it through with looking at your denials to figure out where or when they want it used, because it is deviating from the use case set up by Medicare, which is still not going to be implemented till post 2024.
Yep. Good advice there. Thank you, Amanda. And so, Debbie, what do you think about reimbursement parity? What is it looking like for specialty telemedicine visits? What's your crystal ball telling you?
Oh, that my crystal ball tells me we got a long ways to go. So just to make sure everybody understands, there's really 2 types of parity requirements. One that has to do with service parity and one that has to do with payment parity. And a lot of people get that confused. So we just need to make sure that you're understanding that 43 states in the District of Columbia have a law that addresses the service parity, but only 24 states have a payment parity where they're paying the same amount as they would for an in-person visit. So, you know, those are things to keep in place. I think that what I'm hearing amongst those that are talking about this is they don't think we're going to get a true payment parity ever from a federal standpoint, because people are still not looking at it in the light of we're replacing one with the other, that it costs less to do a telehealth visit. So I think that those are the things that we need to be looking at, working with our congressmen, trying to get everybody to understand why telehealth can replace that in-person visit, and we can do as much. As more device interaction comes into place with home devices and things like that, I think that will get turned, but I don't think it's going to be a true payment parity for several years to come, unfortunately.
Yeah, and we know that there's always requests from organizations that are doing data mining for CMS because they were always asking for more data. So if you are a large organization or a small organization that has telehealth visits, please capture that data. And if you wonder where you should send that, please send a message to me and I'll help you and direct you to where you can send your information so that we can help our legislators understand the scenario and how telehealth is going to be used. And so one of the things that's been in the news sort of every day is around this DEA changes, Debbie. And, you know, I know that you've been kind of knee deep in this for several of our clients. So talk about what do they do? What do people do if the DEA proposal stands as it is today?
I think the biggest thing is just making sure you understand what the proposed rule will be. The biggest thing that's going to come into place, some of them are making sure that the DEA rule says that a provider can prescribe a 30-day prescription. If they do the refill, they have to have an in-person visit with that provider in order to do a refill. The other big thing to keep in mind, if we created that physician-patient relationship here in the PHE, and there was never an in-person visit, they are giving us some leeway that we're going to have 180 days to get that in-person visit completed. If you cannot physically see that person in person, they would have to go seen by another DEA approved provider and have a telehealth referral within that 180 days or even the 30-day requirement. So it's really important to know what those rules are and make sure that you are compliant, because they will start auditing that. The other big change is the documentation requirements are changing, where we have to document a little bit more on what prescriptions are how they're prescribed, who's prescribing them, who did the referral. So there's some changes on that you need to make sure that you're aware of and follow.
Great, thank you so much. As usual, Amanda, we have a lot of coding questions. I know we've got about 5 minutes or so, maybe 6 minutes. Again, trying to keep it within our lightning time frame. So if we go over, I want to make sure that we get the couple questions that we also have added in our for our live participants as well. But what about the box 32? Has there been any decisions made on box 32, whether that will show the provider home address or not, if they're credentialed from home and see patients from home? And they had some comments about what they had heard at ATA during that session. So what are your thoughts on box 32 and the home address?
Yeah, so multiple payers use that form. So you would have to check payer by payer, but essentially CMS extended that you could use your where you would have saw the patient in person if it was provided in person. So you could continue to use your POS 11 and your POS 11 address. If you're only registered at home and conducting things at home, there might be a potential in the future, and it may be required for other payers that you got credentialed under, that you have to enroll your home and report your home address. The box 32B just includes the address of the place of service. So before the public health emergency, it was the address at which the provider was when they were providing the service. So if we followed those rules, yes, you would need to put your home address in that box.
Thank you for that. And then another question around post PHE for direct-to-patient telehealth provider-based coding and billing through 12/31. Are we to use point of service 11, 22, et cetera, with modifiers, or are they switching to point of service 02? And they've gotten some conflicting guidance.
Yeah, so that again is payer related. So if you have a 11 for, if you have a location of 11 for CMS, you can continue to report 11 for now. Again, I'd recommend you keep an eye on the July proposal, because CMS is saying that they are going to go back to business as normal with telehealth. So the proposal that's going to come out is going to be the conditions of what would be covered the next year. And they might have some clarifications within there for what's going to happen in 2024. Other payers are asking for 02 and 10. But again, the 10 wasn't really set up well by CMS, and it hasn't been rolled out clearly on why that use was made. To me, it seemed to capture a policy for CMS to catch the 10, which was to exclude other codes or services that wouldn't be allowed under the federal regulations to home. But now payers are picking it up and are saying basically just use 10 or 2. You have to work with your revenue team, your lawyers, and identify the risk with that. And as I stated, the risk should not be a payment risk. Both should result in the same payment. And the biggest thing you want to make sure is you're not overcoding or overbilling for your service. So unfortunately, there isn't a clear answer, but you should identify your risks associated with both.
Good point. And we're going to go to some of the live questions now. And Debbie, it seems like there's been no single source of truth for post PHE and telehealth. There is legal and regulatory documents, but everyone has their own spin. Do you have a single source location that you would recommend, or what places do you go to that are trustworthy for you?
Oh, you're on mute.
Sorry, I was on mute. So I really rely on the Center for Connected Health Policy as a source of truth. They're a federally funded resource, and I think that they do a very good job. So I think that's one of those that I go to. And then again, the CMS fact sheets are the other area that we use a lot as how we identify what the rules and regulations are. But the Center for Connected Health Policy is probably my one go-to place.
That's your go-to. Do you have one, Amanda?
I would say there's always 3. So there is, a great resource is at Center for Health Policy, Connected Health Policy. You can find a lot of stuff on there, but I believe everyone should always look at your CMS rules, which are going to be your federal rules, your state laws, which may not line up with your federal laws, because remember, we're still under temporary extensions to waivers from the federal standpoint. So you need to know, once those waivers go away, what's your state-based laws? And a lot of the times you could find more information on your state-based laws within your state-based Medicaid program, because they're going to follow the state-based laws. So those are the three sources that I find you could get a pretty good grasp on what you can do in your area or in other areas if you look at those three sources.
Yep, I agree with that. There are others that you could pick on, but I would rather, for the purposes of this conversation and the question that was asked, I think those are great spots to just get the right information and not muddy the waters with other things. So another live question. I understand the fee schedule for telehealth will change after the PHE. Can you clarify when this change will apply and what fee schedule will apply when it does, i.e. no longer covering any originating site fees?
I'm very confused by this question. So the originating site fees, I'm not sure why you're saying they are no longer covered. Originating site fees are still covered under the reasons why they could be covered in the past. You might not have applicable scenarios that were only PHE scenarios in which you could utilize it, but the typical scenarios you should be able to still utilize your fee. The fee schedule has been set for 2022 from CMS. There's not traditionally changes to the conversion factor or fees during the middle of the year. Pay attention to July for what's coming out as a proposal to change to those fee schedules. The only other thing I could think of, if you're talking about a change, is the potential difference between getting paid for the parity, which is getting paid the office rate, or getting paid a facility rate. And that is, again, going to be payer to payer. CMS said they will extend it to the end of the year. And you're going to have to just check with your other payers if they're accepting O2, or are they also deviating and reducing the amount. CMS also said for 99441 through 443, they will continue to pay at an established patient rate, but that will come up in the proposed rule for what they're doing with that rate for the following year. So you might get different rates, or meaning the underlying fee schedule that wasn't the PHE fee schedule comes into place for certain payers. So you might get reductions, but the fee schedule wouldn't change. It would just be which of the costs are they paying post the public health emergency.
Right. We can see that they're all cycling to the standard physician fee schedule. And that's not a bad thing. It just makes it everything at that end of year, which we're used to for other physician fee schedule pieces. And last question, unless something comes up in the Q&A, because I know we're right at 2:19. We don't like to go over 20 minutes for these. Debbie, how would we fix virtual visits in ways that are now compliant with state and federal and local regulations? So I think this question is going to the changing aspects of telehealth, right? And what we're going to see in the future. So how do we deal with that today?
Well, I think the first thing is we need to make sure that you're using a HIPAA compliant application. So during the PHE, CMS did allow things like FaceTime and those non-HIPAA compliant applications to be used in the early days. So you need to make sure that whatever you're using is HIPAA compliant. Yeah, you also need to review, like was mentioned, your individual state requirements, because each of those are different. So you need to make sure that we're following that. Look at the CMS 2023 physician fee schedule will tell you what you can and cannot bill for from a CPT code. And then my last recommendation, if you don't have optimal rules and regulations for your specific state, work with your legislators and the hospital boards and the medical boards to get those changes made for the future, because that's the only way we're going to be able to grow this and make it sustainable.
Yep, absolutely. And I think when we do our own regulatory and reimbursement analysis for clients, one of the things that we recommend is we look not only at the law of the state itself and what is in law today, but also what's pending. So sometimes there's things that are cycling through committee. And in addition, we look at the scope of practice requirements from the medical boards or from the nursing boards, whatever type of qualified health professional we're investigating at the time. So it's always looking at both of those, because the law might allow it, but the scope of practice might not allow it. So it sometimes can be in conflict. And advice and guidance to folks also is around, if the law is silent, then you have to decide what level of risk you're willing to tolerate. Sometimes organizations are okay. If it doesn't specifically say no, then they're okay to go forward. If it doesn't say specifically yes, then they sometimes have a less risk tolerance. So you have to decide that for your own organization. But it does happen, and sometimes there's nothing addressed inside the law. We did record this webinar. Thank you, Amanda, and thank you, Debbie. We don't have any further live questions. We did have a great crowd here today. This is recorded, so this will be on our website. If you have other topics that you'd like us to cover in the future, please send those to us at info@blue-cirrus.com. We're happy to do webinars on any topic and educate you and the public on the topic of telehealth and what's happening in the virtual health space. Lots of things happening in the next few months. Our next webinar, I believe, will be on AI and machine learning and how we use that in telehealth and what the future looks like there. So thanks you, Amanda. Thank you, Debbie. And thanks to all the participants for participating today. Have a great day.